I'm Andy Coburn. I'm with the Maine Rural Health Research Center and the Flex Monitoring Team, and want to welcome everyone to the second webinar that we're having on the Innovative Projects Evaluation project that we're doing with all of you. So we're really delighted that we have 4 presenters from Michigan, Tennessee, Illinois, and Colorado to talk with us today about their projects, which focus on care coordination and quality improvement, and we're really looking forward to those presentations. With that, perhaps we should proceed to the first presentation, which is going to be Illinois. So with that, Pat, take it away.
Thank you very much. Okay, just a brief background about our ACO, and you're probably all fairly familiar with it. I've talked about it for a while. We've been in it for 3 years. We're beginning our renewal. It's statewide. We have 22 critical access, 2 independents. We have a number of rural health clinics, and we really are covering area that really is professional shortage area. We use the AIM investment funds to help ramp up our ACO, and we have a variety of EMRs. So we have our challenges as an ACO, and I'll move to just a little bit of background, but I'll move to our project more specifically in just a couple minutes. But just giving you a background, and we use some of the funding from the Flex grant to support some projects, initiatives within the ACO that we wouldn't be able to do, and I know that's what you're wanting me to share today. Obviously, you can see how we're spread across the whole state, and our journey has been rather unique. It's managed by iCare, the corporation, which you're familiar with the Critical Access Program and the Flex Program, and we really have followed this format and the fact that, we really learned about the ACO in 2015. We kind of tried to figure out how it's going to work. This year, we've really been trying to make a difference in our numbers, and next year, we really are working on sustainability. We know where our costs are, and we have strategies now to reduce them. So it's not something you learn overnight, and it's become a real cultural change, and it's also innovative. It's made us think differently about healthcare delivery, and so I really credit that for us. Really has made a difference for our hospitals. As any ACO, just to refresh your mind when you look at an ACO and how you get started, and like I said, once again, this prefaces my actual project so you can understand why we chose it. You look at population health, how are you going to improve the overall care, your data, quality and education and training. These are, obviously strategies that anybody would use in working with an organization, and ACO is no different. I use this slide a lot. If you've heard my presentation, that you have to think about your population in really 4 quadrants. And, you have your healthy patients, early onset, full onset, and complex. And you have different interventions that you do for each one. And the interventions that I'm going to talk about are really those that deal within the chronic disease category, and talk about transferring of information and congestive heart failure and COPD. We use it for our ACO. Really, you just can't turn the switch, so you have to do a lot of hand-holding and individual work with hospitals. And so we ask the hospitals to have their own approach. Are they going to have a team or 1 or 2 individuals? And then we, as the ACO, have regional nurse managers that work individually. Each of our hospitals have a playbook that they have to, identify their top high-cost patients and high-risk patients and how they're monitoring them through the system. And so it's it's a whole overall effort, but you have on-site with the individual participant, like the hospital or clinic, and then you have the ACO and its support service. Challenges, as you know, this is one of our projects, is when you transition from one setting to the next, communication can be really a barrier. And one of the things that we also know in that is transferring information, particularly with medication usage. In the elderly population have, the polypharmacy, and when you go from one setting to the next, do you stay on the same medication? Are they put on new medication? Do you discontinue? So there's a lot of information that needs to happen, and we haven't always been very clear about it. We've learned that our EMRs, they print out these beautiful discharge instructions, but a lot of them there aren't individualized, and so we've had to learn how to communicate from one transition to the other. So our project focus has been in 2 areas as I've been moving towards. One is improving transfer communication between facilities. And we started out looking both at the tertiary care from a CH to a resource center or tertiary care, and then the CH to the long-term care setting. And we decided we would work more with the long-term care setting because we felt we had a more immediate impact with that, with the Medicare population in particular. The other area that we focused on was congestive heart failure and COPD. As you're all familiar with those chronic diseases, and you know that they're really top ones as far as, elderly and Medicare beneficiaries. And so we knew that they're, a high user of our hospital. Most of them are what we call frequent flyers, going in and out of the hospital for admission, readmissions, in and out of nursing homes, readmissions. They're going from the hospital to the nursing home and back and forth, and particularly from the emergency department. We've learned a lot about how we discharge a patient from the emergency room, particularly with congestive heart failure and COPD. But we wouldn't have tackled these two projects. We would have looked at the ACO as a whole and how we can manage and change population health as a group, but because we had the flexibility of the grant program, it allows us to, suggested to us, let's do some innovative work and let's hone in on a couple of areas that we could focus on. For our first project, the communication one, is we had 8 pilots. It's 8 hospitals served as a pilot, and we spent a lot of time analyzing the communication tools back and forth. And from the initial studying, we had 38 facilities. We reviewed their records, and you can see we saw some commonalities, but we also found areas that we could improve. And one of the things in particular is that we know that if we have readmissions or have difficulties with transfer, what we're encouraging is the hospital and the nursing home. So after we had this for the first year and we're moving in our second year, we continued these discussions, and we've been doing a lot. We've been doing roundtables and community meetings with each of the hospitals and nursing homes, and have been focusing in on the communication tool and information. And so in doing that, we've learned it's kind of that drill down or dig deeper approach, and we're learning that it's nurse-to-nurse communication. We're not clear. Transfer times aren't down. A lot of things that we've learned that we've been able to correct. So our challenges moving forward is that we're all in different geographical areas. You have caregivers that are involved in the process. Not all are we consistent with our communications. And so, once again, the grant followed and pulling the pilots together and gave us an opportunity to really focus on an area and identify key things and build interventions to follow. So with the next steps, you can see some of the things that we're working on is we're finding our tool. We're continuing our nursing home and hospital roundtables on a quarterly basis, and we're working closely with our medication, trying to make sure the information on medication use is clear from one setting to the next. Second project is our congestive heart failure that I talked about. The first step we did was just do, this was back in 2016, where we really did a review of what did our population look like. And interesting enough, in our ER population, CHF and COPD were not the primary diagnosis. We had to drill down into the charts and find that, because sometimes they came in as shortness of breath. Once again, that, which is significant because it's a coding issue, and we have to figure out how we're going to track and research, is that you have clear information to follow from time to time. So our initial findings, we had average visits of a congestive heart failure. That's really too many within the year's time. One should have been too many, because they really should be going in and out of their primary care office on an ongoing basis. They live at home, and we really found these are a listing of the symptoms. Our discharge instructions clearly missed a lot. None of them were on daily wait. None of them were on when they're going to have their next appointment and so forth. And part of that was we found indicative of the EMR discharge instructions. They were not individualized. They were very generalized. We realized with the Medicare beneficiary population, they need clear and better instructions. So communication, once again, pops up as a major issue that we have to resolve, whether you're in a rural or urban setting. And other things as they live in their home and they have edema, and this gives you an idea of the medication that they're on, and it really was not much common with that, other than medication instruction that we need to be clear with that. Okay, we've added some readmission determination. We've been really focusing on community resource tools, getting them in where, caregiver help, getting somebody to come in and check on a patient, and really trying to connect them into their primary care offices as much as possible so that they're not going in the emergency department with severe shortness of breath. And, in doing that, we've really improved the communication not only with the caregivers, the wife or the daughter or the uncle or whoever, you're dealing with, that we've worked at, better discharge instructions. Not only we've focused on the emergency department, our next is better discharge and communication instructions from the primary care setting. All these things make a difference in keeping people healthy and living at home and not having to go back into the hospital. Our challenges that, it's hard to get everybody on board. We have such a big project. We have 24 hospitals involved in this. The whole ACO is involved in it. And so it's a constant struggle to keep people informed and concentrating on COPD and CHF and making sure that they're consistent in their discharge instructions. And we're developing tools so we can begin to standardize. Our chief medical officer has been conducting educational programs with our medical providers so that we really focus in on standards of care and keeping patients in the primary care setting, that they don't get into exacerbation of their illness. So final thoughts, like I said, I'm really a big proponent of the FLEX program. You've heard me talk about this over the years, that it's allowed us to do so many wonderful things, and it gives you an opportunity to be creative. The ACO, we probably wouldn't have spent the money. We would have looked at a broader picture. This allowed us to really focus in and hone in, and I can say to the hospital, this is a special grant project for the federal office that we're going to be able to share with other states, and this really gives a bigger imprint, and it gives us a bigger voice when we go out, that this is really important to the betterment of our rural communities. So additional, if you would like information about our readmission huddles that we have, the worksheet and the toolkit that we use for hospitals and nursing home, I'm happy to share that. Some of our patient education and practice tools, and these are some of the things that we truly try to put in hand of our hospitals so they have guidelines. I think that's it. So that's my contact information, and Angie really has spearheaded these projects because she handles more of the quality and the clinical programs in that. But, these are two programs. These are high usage of the patients, with congestive heart, COPD, and our Medicare population. Really affects our quality improvement, with patient satisfaction surveys and so forth. It's just really integral, and if we can improve those areas, then we can take those same guidelines and then work on hypertension and other types of chronic diseases. And then the transfer pieces allows us to improve communication from one setting to the next, and that's so critical, and it really continues to break down those silos. And if we can improve those, we've made one step further to really the patient being your patient throughout the whole continuum. So I think that covers my part. And
why don't we just pause briefly here and see if those of you who are in the webinar would like to ask any questions at this point.
We're welcome to share our tools that we use for chart review and things like that if you would like to do those individual projects with your hospitals, or if they'd like to have copies of that. You have to start somewhere, and it's kind of like that old quality improvement, high risk, high volume, high cost, and, that's, we really looked at our data and decided those were key areas that we would start with, and they really are making a difference. We're seeing changes from that. Slow but sure.
I'll just make a comment that I was really impressed with the focus on nursing facilities, because I think there's just a tremendous amount of improvement work that could be done, but also incredibly challenging given the nature of nursing facilities being so different, both in culture and structure and in lots of other ways from the critical access hospital setting. So congratulations on tackling what is a really important but difficult problem.
We know that we have to work together, and we just haven't done a good job of it the last number of years, and we can do better. And we're seeing the efforts pay off locally. So thanks, Andy. I appreciate the opportunity.
Okay. So our next presenters are from Michigan, and you're on.
Well, good afternoon. I'm Jill Oesterle, the manager of the RH services here at Michigan Center for Rural Health. Just a bit about me, because I haven't been part of this group, so I'm new to Michigan Center for Rural Health back in October, and we'll be working closely with the rural health clinics throughout the state. We have chosen the Michigan Rural Health Clinic Quality Network. Next slide. We have chosen the Michigan Rural Health Clinical Quality Network as our project that we're working on. This network is in name only. We have been working to gain popularity with our rural health clinics and gain more of a membership instead of we hold quarterly meetings and having them sometimes show up, sometimes not show up. So really trying to formalize that process. 2017 this year, we really started to work towards formalizing that process. We began with nominating and then electing executive board of directors. They are really driving this committee now. We've tried to hand that over to them more and more to be able to be the ownership and the workforce behind this network that we're putting together. We have also then requested our clinics who participate to do a memorandum of understanding. We felt like this was a necessary part of the infrastructure to make the project successful. And all of this really revolves around the quality piece of the tracking of the network. QHI is how we track that quality. That is something that we've embarked on with many other rural health clinics throughout the nation, so that we do enter our data monthly, and I'll get more into that. We've also added a due structure. That's something that we didn't have before, and we're hoping to engage and hold people more accountable for participating and so forth. Of course, they hired a full-time employee to do this, and this is myself, of course, along with a multitude of other projects, but we're really excited to have more time dedicated to the rural health clinics and the quality network program that we're supporting. Next slide. Our project goals this year is really to increase those number of RHCs who participate. We want it to be revolving around that quality reporting. Previously, it had revolved more around compliance. We had the group actually select their components that they wanted to track. The three that they selected as our core measurements are BMI screening and follow-up, tobacco use, and then controlling high blood pressure. We are using the NQF criteria for meeting those measurements, and they do, again, submit their information on a monthly basis. Next slide. So our project overall is to work with the certified RHCs in Michigan. We really want to build a robust set of clinical quality measures. Moving past this point of beyond the three measures, we want to be able to engage the clinics in reporting more of those measures and utilize this data for the clinics to have some comparative data, to know where they're at in their marks, and work together as a network. We will be using the best practices and facilitate improvement in the Michigan's rural health primary care settings. This group is a very strong, knowledgeable group, and they've really made some strides over this last year. As I mentioned, the RHCs submit 3 core measures to the quality health indicators on a monthly basis. We're doing this however they want us to do this. If they want to log in and input the data themselves, they do that. There are some clinics that don't have the time to do that, so they're sending the information to us, and we're actually entering the data, and hopefully to be able to build that robust database of information for the clinics to use. Next slide. The why. Michigan Center for Rural Health strongly believes that RHCs in our state need to build their capacity in future payment methodologies. We all know that they're not mandatory yet, but RHCs will be mandatory in terms of quality reporting. Other payers, Blue Cross Blue Shield, are already investing in the value-based programs. In rural health's transition to larger outpatient focus, we know that we're going to have to be able to have that capability of reporting those measures, and we want to be on that forefront of giving good quality information to our clinics where they can go back and then they can make changes in their own clinics and have that information for them to use. Also for advocacy purposes, we have strong clinical data to showcase that the care that the RHCs are providing is good clinical quality care, and hopefully that will help us in the long run. Next slide. So some key achievements that we've obtained so far is we do continue to have our quarterly meetings. We continue to increase our attendance and more consistent attendance as well. We've also formalized the network and begin to utilize the board and the executive knowledge that they bring to our committee. They are all seasoned practice managers, directors, other clinic administrators, and they bring a lot of knowledge to the group and help guide the group in where we're taking the clinic or the quality network. Again, having a memorandum of understanding by RHCs has been a milestone. We are continuing to collect those from the clinics throughout the state and getting more people on board. Having the QHI submission is a component of the memorandum of understanding, and people have bought into that. And then again, another key achievement is we are getting more consistent QHI data submission. So we're really pleased with that. Next slide. Here is just a sample agenda. This was our last agenda that we had in November. We try to keep the meetings really diverse and allowing different speakers, allowing different topics. The focus is quality. We always start out with the quality component within the agenda. That's our focus, but we also want to keep people engaged. So we do bring other topics and other information into the agenda throughout the afternoon. This last month we had behavioral health integration. We also have updates from Nathan from NARC, and it provides a really comprehensive afternoon in providing information to our RHCs. Next slide. So, of course, challenges and barriers. We do have consistent data into QHI being one of our barriers. There are months where many of the clinics will input their data and then months where we are very slim on the data coming through. We want to make this a project priority for the different practice managers and making sure that we're doing what we can to eliminate that barrier for them. We want to also shift from compliance, which has been one of our previous focuses of these meetings, providing compliance support and information, to more of a quality focus. This is something that's still a challenge. We actually just put out a survey over the last couple of weeks wanting to get information on what are they looking for. And compliance still is up there in the top 3. Excuse me. Setting a process for overcoming those barriers. We have, again, myself that has been dedicated to move this project forward, and also allowing the RHCs to send data to us. Again, if we need to submit the data ourselves for the clinics, then that's what we're willing to do. Also aligning the QHI data submission with the Michigan RHC QN strategic planning. So later in December, we're actually getting the executive board together, and the 2 components that we're really highly looking at to be a key component over the 2018 year is the quality reporting data and then other financial reporting data. Next slide. Our partners that both attended the Quality Network meetings on a quarterly basis is MPRO, for the Quality Improvement Organization, and then for the physician organization, we have Medical Advantage Group. They also bring a wealth of knowledge, and they're a resource for our RHCs throughout the state. Again, very knowledgeable individuals that attend our meetings. Next slide. So, of course, the role of the FLEX program has allowed us to do a lot of these different things throughout the year. They fund the annual QHI fee to be able to utilize that database, staff time as myself. Also that we reimburse the participants mileage to and from the RHC-QN meetings, hoping again to engage them to attend and participate in our meetings. Everybody knows that with some of the smaller communities, it's difficult in terms of financial costs. We have people who travel from the UP to the middle of Michigan, which typically is anywhere from a 4 to 6 hour drive. But they're great in attending and great in submitting their data. And then also the meeting costs. And then next slide. And I think I did it even quicker.
Thank you very much, Jill. Terrific in terms of keeping us on time. And maybe we'll hold off on questions until we get through all the presentations at this point.
That sounds great. I'll be on the call.
Great. So,
all right, I'm just going to begin. I'm Bill Mize. I'm the Executive Director of the Upper Middle Tennessee Rural Health Network. Just a quick perspective on the Rural Health Network. We've got 5 hospitals that are part of the, directly part of the network, 3 critical access hospitals and 2 PPS facilities, but we also have associate members, which includes some tertiary facilities, quaternary facilities, even downtown. Vanderbilt comes up to our meeting up in Macon County, Tennessee, which is really interesting. And we have HCA being part of it too. They've got some representation. So it just gives you, and then we've got 2 FQHCs and some other local providers who participate in our network. So we've been in existence since 2006. Just from our project overview here, we've been working to set up and assist our rural practices in our area to prepare for the value-based purchasing, engaging the local physicians and also FQHCs as well as the local hospitals. But we set up a base and an alpha project in Macon County, Tennessee, which is in Lafayette, not Lafayette, but Lafayette, Tennessee. And we've targeted, we've got some, the great technical and operational assistance from eTransX, Richard Taylor specifically working with us to get things going. And we wanted us to get into this value-based program and with the concept of moving forward with it without having someone telling us how to do it. I think we are in the process of setting it up where we can have had some empirical experience with it. So we got moving, and we wanted to create a model which was what we could that could be replicated by the other members of our network, as well as other rural health networks. We also have a great deal of activity from the Tennessee Hospital Association that attends and by the way, the meetings take place monthly up in Macon County. The implementation strategy was to take a look at the options that we had for a model and select a provider and set the alpha project up and then roll it out and see how it goes. And we used the value-based purchasing model in focusing on the chronic diseases of diabetes, COPD, frequent use of the ER, and the other one slipped right off the top of my head. I can't remember. It was asthma. And again, we picked eTransX and Care Harmony. Care coordination is absolutely vital with this. And that's why we need to set up a model that works and the interchange between the patients and the relative to the non-clinical parts of the interaction with patients, specifically their social needs. How do they get to the next doctor's appointment? Have they got their prescriptions? All of these are key things that, and then making sure that the patients understand their discharge instructions. And what we do with that, with our care coordinators, is most of the time when patients are being discharged from the hospital, they're not listening to the discharge instructions. We follow up and have them listen to the discharge instructions, or have the care coordinator go visit the patient and go over the discharge instructions. This will reduce hospital admissions specifically. And so we've got the CCM project successfully launched, and we've got several patients who have been successfully enrolled. In the state of Tennessee, Medicaid, which is called TennCare, is cost-based as well as Medicare for critical access hospitals too. I think that's pretty much what I'm going to just introduce it with. If I missed anything, Richard and Jeannie?
I think that's good, Bill. Next slide. This is Richard Taylor. I worked with Bill and Jenny and the Rural Health Network in putting this together, and wanted to back up a minute. As Bill shared with you, we selected the Chronic Care Management Program as the initial value-based model that we wanted to start with, and this is the logic model that we use to select that program. And we had assistance from the Flex Monitoring team on putting this together. And we had input from many of our stakeholders that are members, voting members and non-voting members of our Rural Health Network. And we took a look at all of the different value-based healthcare programs and strategies, such as ACO that Pat in Illinois used. We also looked at patient-centered medical home. We looked at transitional care management. We looked at CPC+. But we decided that the program that we wanted to initially start with needed to be something that would be suitable for our particular region. And as you know, in many rural regions, most of our practices and providers are smaller practices, so we needed something that we could start with that was logical for the requirements in terms of resources and funding to get started, but that's something that would have an impact that we could show results. And so this is, again, we're going into detail, but this is the model that we use to look at what are the outputs that would be required for value-based health care, what are some of the short-term outcomes that we would like to look at, what are the intermediate outcomes, and then what are the long-term outcomes that we would like to achieve. And so the things highlighted in red are key components that we focused on as we narrowed down the options to something that would be easy to implement and give us a success story as we move forward. So next slide. We selected the Chronic Care Management Program, and the reason we selected this program were four. One is that it was a sustainable model in that the program generates a $35 per patient per month payment for the program. And this came from both Medicare and the Medicaid program in Tennessee, TennCare, that was participating in this program. And then we felt like the chronic care management would provide a foundation for supporting future value-based purchasing models, such as CPC+, our Medicare Advantage contracts, or, importantly, the MACRA-MIPS program, where the practices will be scored on how well they're doing on their quality scores as part of how their payments would be adjusted for the Medicare patients. The third reason we selected the Chronic Care Management Program is because we felt like this program would lead to better patient health outcomes, and it could also help promote loyalty to the provider for the patients that were receiving these additional services to help them coordinate their care. And then the fourth area would be a low-risk implementation process, in that we had a turnkey solution from the vendor that offered the turnkey chronic care management program. And so because they offered the turnkey solution with the care coordinators as part of that solution, there would be minimal impact on the existing provider staff, and also, more importantly, there would be no upfront capital needed to get this program started. So these were the four reasons that the Rural Health Network chose the Chronic Care Management Program as the initial program for moving down that path towards value-based care. Next slide. Just to give you an overview, some of you may be familiar with the Chronic Care Management Program, but for those of you that are not, basically this program involves identifying Medicare, and in our case, both Medicare and Medicaid patients that have two or more chronic conditions. And then once they're identified, you invite them to enroll in the program. They can be enrolled by phone if they've been in the office within the last 12 months, or they have to come in the office if they've not been in the provider's office within that 12-month period to enroll in person. And then the essence of the project is to have the care coordinators and the nurses and the care team work with the patients to develop a care pathway, which is how we're going to help you manage your chronic health conditions, whether it's diabetes or asthma or COPD. Those are the diseases that qualify for the program. And that's not us with the music.
Yeah,
even though we're here in Music. Yeah, even though we're here in Music City, USA. Next slide.
Put it on hold.
Okay. This slide gives you an overview of how our care coordinators work with the patients. And these are 2 example patients that have 2 or more chronic diseases. And the 5 things that are part of that 20 minutes per month is helping develop that care pathway, that care plan, providing patient education, conducting routine assessments as needed, doing referral management, referring them to specialists or other providers as needed, and then monitor how well they're doing and make sure they're following up on their care plan. Next slide. In terms of what we are projecting for a potential financial, again, sustainability for this program, is that based on 500 enrolled patients, whether they're Medicare or Medicaid patients, the projected income that could be generated for a particular practice or provider would be about $200,000 for the year, assuming that 500 patients were engaged and that those 500 patients stayed in the program to receive the 20 minutes at the minimum of services for the duration of the program. And this is based on an average payment of $35 per patient per month based on what the Medicaid program pays as well as the Medicare program. Next slide. The challenges and barriers that we encountered as part of this project, we wanted, as Bill shared earlier, we wanted to pick an initial provider for this program. And these 2 providers that we reached out to did not have the capacity to do the program. And another reason was one of them did not believe that the value-based programs would be moving forward. And so this is when Hope Family Health, where Jennifer Deddes is the director, stepped up to the table and said, yes, we'll agree to be the pilot provider for this project. And once we got started, we had several delays related to getting a contract in place between the Rural Health Network and Hope Family Health. And this was due to legal reviews that took a while longer than we thought it would. And once we finally got through the legal reviews and got the contract signed, the next challenge that we had was trying to obtain patient data from the Hope Family Health EMR vendor. The EMR vendor was not cooperative in providing timely access, and we had to do some threats to get this information because we could not start the program without the patient data that was housed by the EMR vendor. And so we finally got the data from the EMR vendor, and then we had another conflict with the third-party billing vendor that was used by Hope Family Health. And that vendor was not familiar with the program, had not done this type of billing before, and so it took some time to explain to them that they would need to bill for the Medicare and the Medicaid payers for this service that was being provided. And so we finally worked through that issue, and then once we got up and running, we still had some operational communication issues with the patients and with the practice staff, in that the patients would be called by the care coordinator to enroll them in the program and start the program, and then patients, having not had advance notice of this, was concerned this might be a scam, and so they would call the office to make sure it wasn't some kind of fraud or scam, and so we needed to work out sending advanced information to the patients so they would know the call would be coming, and then we needed to make sure that everyone in the practice that answered the phone knew about the program as well so that they could provide information, and then making sure that the the whole care team also was familiar with what was going on with the program was one of the operational issues that we had to deal with.
If I can interrupt here, Richard, this just goes to show why we had an alpha project, so we can just get into this and have an experience where we can know what works and what doesn't work. And Hope Family Health and Jennifer did this with her team have been just very, very good and very cooperative. But again, it's the interaction with all these different entities relative to value-based health care. And again, having this experience now, we can move forward to other practices now based on that positive and negative aspects but it's just the knowledge that we've gained as a result of just jumping into it.
Yes, next slide. So these were the key facilitators. Bill, myself, Jennifer, and Kristen was the assigned project manager from Hope Family Health to facilitate the program. And next slide. And we'll be glad to answer questions here. Again, this was a partnership between the Rural Health Network, eTransX, and Care Harmony, and Hope Family Health to launch the Alpha Project. And each of the groups, the Rural Health Network, their leadership team provided support and encouragement. Bill, as executive director, kept us moving forward with this project despite all the obstacles and challenges that we had. And then eTransX Care Harmony provided guidance in terms of having worked with other providers across the country on the chronic care management. We were able to share that knowledge with the group as to what was working and what wasn't working. And then Hope Family Health, they were the ones that stepped forward to be the initial provider in the region to do the chronic care management program with the Rural Health Network. The next slide. The role of the FLEX program, they provided funding through the grant to help us plan this project, to help us look at the different options of value-based care before we selected the chronic care management program. They also provided technical assistance through the FLEX program in terms of identifying project performance metrics that we're reporting on. And then the FLEX program is facilitating learning from the other grantees, such as this webinar today, as being helpful information and helpful services related to the FLEX program. The next slide. This is our contact information. Like I said, we'll be glad to answer questions at the end of the presentations. And we appreciate this opportunity to share our story with the others who are moving down that shaky bridge of value-based healthcare.
Thanks very much. That's a really interesting, evolving and developing project. So we're a little tiny bit behind schedule, and so I want to move on quickly to Colorado, your presentation on improving communications and readmissions.
Great, thank you. Hi, everyone. This is Marcy Cameron. I'm the Critical Access Hospital Program Manager at Colorado Rural Health, and as mentioned, I'll be talking about our iCare program. Next slide. So the iCare program is now in its 7th year, and it's providing the mechanism for Colorado Rural Health to address the innovative model area of the FLEX program. So this program began with 9 critical access hospitals examining methods to reduce avoidable readmissions, improve communication in transitions of care, and improve clinical processes contributing to those readmissions, especially for chronic conditions. Next. As part of this program area, Colorado Rural Health has also worked to synthesize data, including clinical quality data, population health data, and financial impact metrics to demonstrate progress and outcomes facilities have achieved so far through the iCare program. And this is just some of the national data that we've collected to make our case for why this is a relevant project. Next slide. So as I mentioned, this program began back in 2010, and we've expanded that program over the years. It now includes our majority of our critical access hospitals. We have 22 that are involved, as well as 34 of their provider-based clinics, representing 24 of our rural counties. Next slide. So our program structure really is based on 3 areas of focus. We provide technical assistance for the critical access hospitals through these efforts that include monthly project webinars. We do one-on-one calls. Those are bi-monthly. We have site visits to discuss specific facility needs and go through their data. We also use QHI, or quality health indicators, for the facilities to report their data, which I'll talk about more in just a moment. We gain their feedback, we provide feedback, and perform analysis to help drive improvement efforts. And as the program continues to grow, we're always evaluating our program and how we can strengthen that for future, and also encourage our peer learning to impact, that peer learning sharing across the facilities. Next slide. So here's a list of our measures. Wow, it's really tiny. But basically, they're controlling high blood pressure. They're hemoglobin A1C per control greater than 9. The diabetic patients with HbA1c test performed, diabetic patients with LDL-C test, and then readmissions within 30 days for same or similar diagnosis. And as I mentioned, we do collect this data monthly utilizing quality health indicators our reporting mechanism. It's very user-friendly, and the participants really like it, and they can benchmark and run some cool reports from that system. Next slide. So these are just a few of our barriers. As I'm sure we're not alone in these. Our participants have a hard time collecting their data or creating reports in our EHRs. They are all wearing many hats, and they're all involved in multiple projects with multiple entities, so making sure that they see iCare as still a priority is always, something on the forefront, especially when you have staff turnover. It happens everywhere in all levels of leadership and on the ground folks. So it's challenging to find out when new staff have changed, and also then to reorient them, to actually orient them to the program, get them trained on QHI, and all that goes along with it. Next slide. So our success, we have implemented EHR user groups for all of the different EHRs being used by our participants, which sometimes have been up to 16 separate quarterly calls. And that number does change based on when our participants switch EHRs. We've recently had 8 critical access hospitals switch to Athena, so that number will definitely change. And then the goal of the EHR user groups is really for the users, anyone that touches the keyboard, to be on the call and share maybe how they've figured out, where to pull a specific data element from, or how they figured out how to run a report. So it's really another peer learning opportunity that we provide that avenue for. Next slide. So here are some data. We're very proud that our critical access hospitals and iCare have achieved improvement in their readmission rates from an average of 5% when the program started to a current average of 2%. For comparison, the readmission rate for Colorado CAUSE not participating in iCare is roughly 14%, and our overall statewide hospital readmission rate is 19%. So they definitely have succeeded in improving that readmission rate. Next slide, please. And then here's a clinic measure. 80% of our diabetic patients demonstrate good blood glucose control. And they're still obviously working on this measure, but they're also utilizing their EHR for tracking when A1Cs are due and triggering notifications for the diabetic educator. Next slide, please. And then we also have them work together, the cause and their provider-based clinics work together on a shared goal, and they come up with this goal, and this is where the communication aspect of the program really comes in. So a few examples of those shared goals are the medication reconciliation, making sure that the patient record is updated on both the hospital and the clinic EHRs. You know, they don't usually have access to each other's EHRs, so they have to find creative ways to get that information updated. Some are using direct messaging to accomplish that. And then scheduling patient follow-up appointments before the patient is discharged, and then making sure, checking back in to make sure the patient actually showed up to that follow-up appointment. And if not, making those patient follow-up phone calls to say, hey, what's going on? Do you need transportation? How can we help you? What's come up in your life? And then making sure the diabetic referrals get transferred to the diabetic educator so they can contact the patient and get them enrolled in their educational programs. Next slide, please. And we've also started reaching out, our communities, we're helping them reach out to their community areas, and they're engaging those outside facilities and other organizations to continue to impact care transitions, readmissions, and care for chronic disease populations. So across the state, CAUSE have engaged their provider-based clinics in these efforts, but also some have reached out to their grocery stores. The diabetic educators working with the local grocery store to have diabetic-friendly food lists available for their customers, so they know when they go into the grocery store what they should be looking for and what to avoid. They're also working with their local library to highlight diabetic cookbooks and support books, and also starting some maybe like little support groups, and then involving the long-term care setting to educate staff on readmissions. You know, in our state we have a few that have issues with their nursing home sending their patients back to be readmitted when it's things that could be taken care of in the nursing home setting. Next slide, please. So facilitators for implementation, we obviously have pre-existing networks and partnerships. We contact the CEOs each year to have them sign a new letter of engagement. That letter includes the deliverables that I mentioned, the monthly webinars, the one-on-one calls, the submission of data, those kinds of things. Then we go on site. We go and meet with the CEO, the CFO, the quality director, the clinic manager, and we also include the IT staff to review the measures, talking about challenges and pulling the data, and then also the team formation, who should be on the team, if they have maybe a champion that they could include, that's always best, and any issues with pulling data that maybe their IT director can provide some support with. And again, the quality health indicators as we go through that as well. Next slide. So our partnerships include, we have a well-known partnership here in Colorado called Healthy Transitions Colorado that we are a member of, along with our local HIN, the Intelligen, the Quinn QIO, our nursing association, our hospital association, what have you. Next slide, please. And so the role of the FLEX program is really through staffing in order for us to perform quality improvement technical assistance with having them providing education on PDSA, process mapping. We have them do a project charter, data reviews, our iCare focus team calls, again, are bi-monthly, our education and information sharing webinars, which are monthly, our quarterly EHR user groups, and our monthly resource newsletter, which we highlight a community success, either in a process that they've created or improved upon, or a collaborative effort that they are engaged in. Next slide, please. And here is my contact information. Thank you so much for the opportunity to present today.
Thanks very much. That's really interesting stuff from Colorado. So this is our opportunity for open discussion and comments, and for all of you to ask questions of the presenters and the projects that they each have underway in their states. So I'd like to just open it up to everyone on the phone, and if you want to make a comment or ask a question, don't forget to unmute your phone. So if everyone's thinking of that burning question that they have, I'll start by asking a question that occurred to me as I listened to all of these presentations, which have to do with quality of care, improvement and sort of care coordination and care management. It seems to me that the whole issue of how to engage providers in these initiatives is common to all of these projects, and I'm wondering if those of you who presented can talk about what strategies seem to work for you or seeming to work for you to engage providers. I know you mentioned this as a challenge, but I'm wondering whether you have any insights into what actually works to help engage providers. And maybe we could start with Michigan. I know you're new to the project in Michigan, but I'm wondering if you have any insights that you've gained so far in how to get more rural health clinics, for example, to be engaged. Or if others from other states want to jump in too, that would be fine.
This is Jill from Michigan. I think more so from my practice management days than from so far from my position here at the Michigan Center for Rural Health is providing the providers, PAs, physicians, nurse practitioners, the data and getting them in front of them consistently. That was one of the biggest challenges that I had as a practice manager, and making them understand where is that data coming from, what's meeting the data, what's not meeting the data. And then also being very transparent with the information. So each provider saw each other provider's information. And that helped them get engaged in the projects. It started internal conversations of what they needed to do as a group, what this provider was doing and this provider wasn't doing. So those boots on the ground kind of answers, that's what I found to be the most useful. As far as the clinics and the operations side in terms of getting the clinics engaged, I don't have a good answer for that yet. I haven't got a good sense from that yet of what all of the clinics are doing to make that happen.
Others want to jump in on this question of provider engagement and clinic engagement or practice engagement?
This is Bill Mize in Tennessee. One of the things that's key to it is the providers are extremely important, but we sometimes overlook and neglect the administrative support staff and making sure that they are well informed about what we're trying to do and how we work together. And I think emphasizing the concept to those who are answering the telephone in each practice and getting the permission from the providers and physicians to have that conversation is extremely important.
And I would echo that as well. At Eaton Rapids, where I worked previously, Eaton Rapids Medical Center, that was something that we did involve all of the staff. We had all staff meetings once a month, and all of the information was presented to the entire staff to provide feedback and able to take measures and engagement of making those changes.
So there needs to be a bit of a value proposition for all the staff in the participating provider organizations and for the providers themselves in the form of the data that you're providing them. Your screen just went. Just a follow-on question to that, because a number of the projects that you all are engaged in involve this problem of data extraction. The value of what you're giving the provider organizations is the information that the provider organizations are submitting. But are there any particular insights that you have about how to make the data extraction process easier for the practices at this point? I know this has been an issue that I've seen in a number of other instances where providers just are so fatigued with data extraction, and it becomes a really big hurdle. So I don't know if there are any insights there.
This is Marcy in Colorado. We tell them to utilize what they already run. So I know their meaningful use report for specifically the clinic has 3 of those diabetic measures already listed on there. So that's we tell them that one's an easy pull. So hopefully that helps them.
Yep. Does anybody use a portal by which the practices are able to go in and just report their data? No? Okay, other questions that all of you on the phone might have, or thoughts or reactions?
Yeah, this is Richard from Tennessee. Just on that last question that you had, we provided the software as part of the turnkey solution for capturing the data because we did have issues with trying to have providers capture and provide data from their EMR, and so that helped facilitate the ability to capture the data that we needed by using this separate system. And then the care coordinators, as they worked with the patients, they just entered the data directly into that system without having to go through an EMR system. At the same time, we are able to provide that data back to the EMR system for them to have access at that level. But certainly being able to capture data and pull it, extract it, is definitely a challenge.
Thanks.
Just to get some feedback from some of the others, this is Jill from Michigan. Do you find that that's a challenge from the provider perspective or more of the administrator perspective, like your practice managers and your other administrators?
I assume that was a question for Richard.
For anyone, really, in terms of where do you feel that the barrier is with the providers, or more from the administrative perspective of pulling that data?
So this is Jennifer Dittis from Tennessee, and I apologize. I got my time zones mixed up, and I joined the call exactly an hour late. So I apologize that I was not on the call earlier. But to just give some input onto the question, I think it's a challenge all around the board with providers as well as administrators. And a lot of it, and I'm speaking from the standpoint of a provider, primary care provider, community health center, and I'm the CEO, but I'm also a PA. I'm a family practice PA for 25 years, and so I can say that there's so much being asked of medical providers in today's environment. Everything is changing, and I'll tell you, those providers, they have a pretty high burnout rate, and it's hard to ask them to do one more thing or to collect, one more set of data. And it's also a challenge for administrators who may not be, real tech savvy and are having to learn it as they go. And so for us, it's been a challenge, all the way around.
Interesting.
This this is Marcy in Colorado, and we've found that the actual providers aren't documenting in their EHR in the same standardized way. So some will be entering data in a field note where others are using a drop-down. So really we try to educate the clinic to go back and do a workflow and actually retrain all the users on where information should be entered so they get correct and accurate data to make data pulling a little bit easier.
Do you have enough, and this is a general question to everybody, do you have enough participating provider organizations and providers to, if you will, make your reports back to those practices meaningful reports? Do you have a critical mass, in other words, of participating practices and providers to be able to drive those reporting systems?
This is Jill from Michigan. I think that we're getting there in terms of the overall data that's getting entered into QI, but we definitely need to continue to make those gains.
This is Marcy from Colorado, and I agree with Jill and what she said earlier, too, about, you know, you have some months where they're great at entering data and then other months where there's very slim pickings. And we have some communities that are just haven't gotten there yet that we continue to struggle with.
And this is Jennifer from Tennessee. I'm not sure if I totally understood the question, but in terms of, bringing on enough providers, we've had a lot of trouble in our community, that I think that we spoke with at least 3 or 4 providers at the beginning, maybe more than that, and but we were the only provider that signed on to our project, and so to the project. And so the other ones kind of thought about it and went back and forth and then ended up not coming on board. And they were kind of saying, well, we're going to see how it goes for Hope Family Health first. And so it's been a challenge. I think there's such an ingrained culture in our, rural community that is really kind of distrustful of new things, of outside things, of things that are not already well known. And so it can be really hard. And also that in the rural areas, a lot of times the providers are already just covered up. They're having a hard time, staying afloat. And any kind of change is just, a lot to ask. So I think we from Tennessee would be very open to any suggestions on, how to bring providers on board.
Okay, if there are no other questions, thank you all for your participation, and in particular to our presenters. Really interesting to see what is going on, and hopefully that gives people food for thought as you proceed with the Flex projects that you're all working on. And with that, I think we'll go ahead and close the webinar. Thank you all.